I'm Ken Anderson, and I'm delighted again this year to update you on the treatment of myeloma and the progress that's happened in the last year in particular. These are my disclosures. I always start with this slide, which reminds us of all the progress in multiple myeloma. We now have 32 FDA-approved treatments, 16 classes of agents, and the median overall survival of patients is markedly improved, with many patients having myeloma as a chronic illness. In particular, in this past year, we have the CAR T cells that are now approved, and we have 3 different bispecific T cell engagers, as I'll talk about in a minute. Now, because of these advances in multiple myeloma, we're able to achieve what's called minimal residual disease, MRD, fewer than 1 myeloma in 100,000 normal cells. And this slide shows you in the non-transplant eligible newly diagnosed patients that in the red line, those patients who get MRD negative responses do the best in these 2 different clinical trials. That's also true in patients who get transplantation as part of their initial treatment. This shows on the left-hand side that if you get minimal residual disease negativity, fewer than 1 in a million myeloma in normal cells, a very deep response, and you don't have any cytogenetic abnormalities, or you have one abnormality, that it may be possible to discontinue treatment if that MRD negativity persists for 1 year. In contrast, if you have 2 or more genetic abnormalities, we probably can't discontinue maintenance therapy. So this is a very, very important point. With the new treatments in the non-transplant eligible and the transplant eligible, we can get very deep responses, MRD negative. And if they're persistent in the absence of genetic abnormalities, just maybe we're going to be able to stop maintenance treatment. Now, new treatments are coming in myeloma, and from the American Society of Hematology, a bispecific T-cell engager called teclistamab was used. Teclistamab is an injection that is given subcutaneously, and it binds to myeloma by virtue of BCMA, and it binds to the T cells in a patient, and it brings the immune system to the tumor. Why am I showing you this? Because in smoldering myeloma, very early patients at the American Society of Hematology, 12 patients treated with this bispecific T-cell engager teclistamab, all of them got MRD negative with fewer than 1 myeloma in a million normal cells. We're getting closer to cure as we use these very exciting therapies earlier in the disease course. Now, at the American Society of Hematology, 4 drugs in combination were established as a standard of care. In this particular study, Kyprolis, lenalidomide, dexamethasone was compared to isatuximab CD38 antibody, Kyprolis, lenalidomide, dexamethasone, both before and after transplant, and also as consolidation treatment. And my point in showing you this is that when you use a proteasome inhibitor, lenalidomide, a CD38 antibody, and dexamethasone, you can get MRD negativity here up to 77%. In the absence of the CD38 antibody, it's 67%. So this is incredible. Almost 80% of patients getting MRD negative. And it really matters. If you look over here on the right, this is fewer than 1 myeloma in a million normal cells. And in all the subgroups, that translates to a better progression-free and overall survival. And then a second big study was presented at the American Society of Hematology, a similar study. This time, instead of isatuximab CD38 antibody, it was daratumumab CD38 antibody, lenalidomide bortezomib dex versus lenalidomide bortezomib dex without the CD38 antibody. Again, before a transplant, after a transplant. And again, the 4-drug regimen did better. Here's daratumumab RVD in terms of time without myeloma or progression-free survival in the red line. And again, as I showed you a minute ago, everybody benefited from the 4 drugs, all these different subgroups, including high-risk cytogenetic myeloma. The addition of a CD38 antibody to the triplet of lenalidomide, a proteasome inhibitor, and dexamethasone can overcome high-risk disease. And this just shows you what I mentioned on an earlier slide on the right-hand side here. If you have sustained MRD negativity for at least a year, you do much better, and it's more common when you have a 4-drug regimen than a 3-drug regimen. So we're treating earlier with novel agents, and we're using 4 drugs together to achieve unprecedented responses. Now, what about maintenance, which is usually done with Revlimid treatment in the post-transplant setting? At the American Society of Hematology, a stronger lenalidomide or Revlimid was presented called iberdomide that's used after maintenance, and it showed that there was a very, very good track record. There was at least 50% of people who had an improvement in their response after the first year of iberdomide maintenance. So we're going to have better, stronger maintenance. And then there's a stronger yet similar drug to iberdomide and lenalidomide called mezigdomide that was presented at the American Society of Hematology, stronger than pomalidomide. And it was presented together with daratumumab dexamethasone or together with elotuzumab dexamethasone. And in both cases, there were high response rates noted in advanced myeloma. So we're using earlier advances, drugs in the smoldering setting. We are using 4 drugs in the upfront transplant setting, and we have new drug for maintenance, iberdomide, and a new drug that's now in relapse myeloma, mezigdomide. Things are really changing in myeloma. Now, I want to finish up with a discussion about the immune treatments. You've all heard about CAR T cells that are primarily used in relapsed refractory multiple myeloma. Shown on this slide is the CARTITUDE-1 clinical trial. It's cilta-cel CAR T cells. And in patients who have had at least 4 prior treatments, you can see here the progression-free survival is roughly out at 3 years here is very, very impressive. And the overall survival median has not been reached. Roughly 2 out of 3 patients, 63% of patients are alive and without myeloma at 3 years follow-up. Now, this particular CAR T cell has been moved earlier. Instead of 4 or more treatments that I showed on the last slide, this is 1 to 3 prior treatments. And you can see that the progression-free survival here is very, very much better than standard treatments. In this example, it was daratumumab, pomalidomide dex, or daratumumab, Velcade dex in the green line. Both of those are FDA approved, but you can see that CAR T cells did much, much better. So the CAR T cells are moving earlier. First in 4 or more prior treatments, on this slide in the 1 to 3 prior treatments, and on this particular slide is the CARTITUDE-6 trial, where CAR T cells are now being tested as part of the initial treatment for patients with myeloma. Here you can see that the trial 4 drugs, like I've mentioned before, daratumumab, Revlimid, Velcade, dex, and then patients are randomized either to get a transplant or to get CAR T cells. And this is a large international trial, but it will determine whether CAR T cells actually become part of the initial treatment or the first treatment for newly diagnosed myeloma. Here's a slide that just include very quickly, because this is a real world experience, not clinical protocol for new drug approval, but rather a real world experience of ide-cel CAR T cells. And you can see there are response rates of 73% and a progression-free survival of 9 months. The point here is that these CAR T cells work terrifically well out in the community, but probably not as good as what we've seen in the clinical protocol setting. And then the other CAR T cell, cilta-cel, is the one I presented so far. This is called ide-cel, the other CAR T that's approved. And again, it's moving earlier, having been approved in the 4 or more lines of therapy population. This slide shows you that in the 1 to 3 prior lines of therapy, just as was true with cilta-cel, the other CAR T, so it's true here with ide-cel, that the blue line shows you patients do better with CAR T cells than they do in this example with 5 different FDA-approved standard treatments in the lighter colored line. Now, CAR T cells take a long time to actually get produced, probably 6 to 8 weeks from harvesting the cells until they're available for treatment. This slide shows you where we've been involved in making CAR T cells literally in 2 days, and then giving back small numbers of CAR T cells, letting them expand in the patient. So this shows you that giving back patients as few as 20 million cells or even 2.5 million cells, letting them expand in the patient, the response rates are very, very high. This is in contrast to the currently approved treatments where, in fact, the cells are expanded outside the patient for 6 to 8 weeks and hundreds of millions of cells are given back. This is much more practical when you give them after you make them fresh and give only a small number of cells. And it really works. This shows you the response rates. They're very, very high here. The doses on the left-hand side. And in fact, these cells can work for as long as 18 months after their infusion. And you can see on the right that many of these patients are having prolonged beneficial responses. This is another target for CAR T cells. All of the previous CARMA, cilta-cel, or ide-cel trials were targeting BCMA. This is CAR T cells targeting GPRC5D. And I mention it because you see high response rates here on the left-hand side. And this is on the right-hand side, the response. If somebody has had a prior BCMA treatment or not, the prior BCMA, you still see responses as shown here on the right, even in patients who have had BCMA therapy when they're treated on this slide with a GPRC5D targeting CAR. And finishing up here, I do want to come back to the bispecific T-cell engager teclistamab. Just to remind you, these are subcutaneous injections. After injection, they bind to the myeloma cell because of BCMA, and they bind to the immune T cell, and they bring the T cell to the myeloma cell, getting increased immune activity and fewer side effects. 3 of these are approved. The first one was teclistamab, 63% response rate, lasting 11 months. This is the real-world experience, again, for teclistamab. Very similar, 64% response rate when it's used out in the community. A second BiTE or bispecific T-cell engager targeting BCMA was also improved, called elranatamab. Again, it's 60% response here. And in fact, MRD negativity achieved in 90% of evaluable patients. And then this is a third BCMA bispecific T-cell engager, the ABV383. This one's different because it's given once every 3 weeks, whereas the others are given more frequently, either weekly or every other week. But you can see here, there are high response rates when these are given every 3 weeks. Just as I said for CAR T cells, so it's true here for bispecific T-cell engagers. BCMA was the first target for teclistamab, elranatamab, and the AbbVie BiTEs. but we have here talquetamab, which targets GPRC5D on myeloma cells. And in the red here, even in patients who have had prior BCMA therapies, whether it be CAR T cell or bispecific T cell engagers, you can see response rates as 63% to the agent, the bispecific T cell engager targeting GPRC5D, talquetamab. Now, what's very exciting is alternating the targets. This was presented at ASCO last year, the BiTE targeting BCMA alternating with the BiTE targeting GPRC5D, hopefully getting higher responses and avoiding drug resistance. And you can see here that in fact, very high response rates were noted when you alternated these two different targeted bispecific T-cell engagers. You have to worry about infections in these patients because when you give the BiTEs, you mobilize the T cells, but then they get tired or exhausted. And that correlates with two adverse outcomes: increased incidence of bacterial, viral, and other infections, as shown on this slide, so that we need to give patients prophylactic mitigation strategies. We give them acyclovir to prevent viral infections. We give them Bactrim to prevent pneumocystis infections. They're on antibacterial infections prophylaxis, and they're also receiving immunoglobulin replacement. And finally, the future is this. We're going to be typing patients for the expression of the target antigen on their myeloma cells. This shows you that an analysis of BCMA or GPRC5D on myeloma cells, and what it turns out is myeloma cells can become resistant to BCMA targeted treatments or GPRC5D targeted treatments by downregulating the target, mutating it so the medicine doesn't bind anymore. And all of these are saying to us loud and clear, we need to profile the tumor before you get these treatments. Even more importantly is the other side. These immune treatments require that your immune system is able to respond. So we know when you get BCMA or a GPRC5D bispecific T-cell engager, there is a proliferation of killer or CD8 positive T cells that correlates with goodness or response. In contrast, when the T cells get tired or exhausted, infection and relapse of disease occurs. So we need to profile what the immune repertoire is like in order to optimally inform how to use these bispecific T-cell engagers. In the future, we're going to be phenotyping or profiling both the cancer cell and your immune system. So here's my final slide. We've had since 1980 in myeloma a revolution in high-dose therapy and stem cell transplant, which keeps getting better. I mentioned 4 drugs are now a standard of care. We've had novel agents that started as a revolution in the year 2000 and continue to happen. I mentioned mezigdomide and iberdomide as 2 examples of new drugs. And then I've mentioned at the end here, since 2020, which is still ongoing, the revolution in CAR T cells and bispecific immune therapies. So my parting thought is that in the future, targeted and immune therapies, including CARs and bispecific T cell engagers, are going to be used in the initial treatment of myeloma. Why? Because we can get these MRD negative persistent responses, so no myeloma. And number 2, equally importantly, we can restore your immune response in patients against their own myeloma. Hopefully then you'll be disease-free and off all treatment. And I always mention this. This is a book on the right, Going for the Cure, written by one of my patients many years ago. She was asked, when you wrote this book called Going for the Cure, how are you going to know that you're cured? And she made a very prescient response. She said, cure is growing old and dying from something else. And honestly, that's happening very frequently today. And I think cure is on the horizon. Best of luck to all of you.